Welcome to Oncology Unscripted. My name is Matt Spraker, a radiation oncologist in Denver, Colorado.
My name is Katie Coleman. I am a kidney cancer patient and patient advocate in Austin, Texas.
And my name is Julie Johnson, and I am a sarcoma patient and patient advocate in St. Louis, Missouri.
We're teaming up to meet in the middle for a candid and educational podcast about cancer that is intended for patients, doctors, and their teams. This show and our opinions are meant for general informational purposes and are not medical advice. We encourage you to reach out to your doctors to discuss your individual case. Thanks for listening. Now let's get on with the show.
Okay, well, I am really excited for today's episode. We have Dr. Wilky with us, and she is a sarcoma specialist. I'm a sarcoma patient, and we're going to talk about immunotherapy. So I'm thrilled for this conversation. Dr. Wilky, could you just give us a quick intro to yourself? Give us a little bit of information about where you work and what you're focused on.
Sure. So thanks so much, you guys, for this opportunity. And I'm also super excited to be part of this podcast today. I can babble about immunotherapy for hours, so you'll have to start throwing things at me if I get carried away. But my name is Bree Wilky. I am a medical oncologist focusing only on sarcomas, and I practice at the University of Colorado Anschutz Medical Campus in Aurora, Colorado, which is just outside of Denver. I have been here for about 5 years. And before that, I worked at the University of Miami for 5 years before that. And that's where I really got into immunotherapy and clinical trials focused on how to boost the immune system, particularly for patients with sarcomas. And then came out to Colorado to partner with some incredibly brilliant immunologists, scientists in the labs, doing really, really cool stuff that I'm sure we're going to talk about a lot today. But I just couldn't resist to come out here and try to take things to the next level and figure out how to get this to work for all of our patients with sarcomas. So thank you again for the invitation and looking forward to it.
We do have patients with all different disease types that listen to our podcast. So I think we maybe should set a baseline here of just how patients should be thinking about the information that you share, given that you are a sarcoma specialist. Have anything to add there just for how patients should be thinking about the information that you're going to bring to the table today?
Yes. So I do focus on a very rare tumor type, but most of what we're going to talk about is really applicable to patients with any type of cancer. I mean, you cannot go online or watch TV and see commercials and escape immunotherapy. And honestly, we were in the sarcoma field, we were super late to this game, right? And to this whole technology. This is work that has been going on for years and years with patients with a variety of different cancer types. So yes, we'll keep it super general. I think, what I will just say is that sarcoma represents one of the toughest groups of cancers in terms of getting the immune system to recognize them. So honestly, if we can get things to work in sarcomas, likely it's going to be applicable to a lot of other cancers that are difficult to treat as well. So I like to think of it as the biggest challenge, but one that could actually pay off and help a lot of other people too.
Well, let's start from the top. We've got, again, patients with different disease types and different stages and even different understanding, various levels of understanding of cancer terminology and things like that. Give us your definition. What is immunotherapy? And just tell us a little bit about how it works.
Will do. All right. So let's start at the beginning. So, a lot of times when patients come to see me with cancer, the first thing out of their mouth is, how can I make my immune system stronger to fight this cancer off? And that's because fundamentally, we are designed as humans to have our immune system to actually be able to defend us, not only against colds and flus and viruses and all those things, but really to defend us against cancer. And so there are cells in our bodies that get mistakes in their genetic code that have the potential to become cancer. And that happens every single day. But our immune system is constantly patrolling and looking for damaged cells. And if it's broken, if that cell is broken, it will send a signal to say, you know what, sorry, but you can't go on living, and that cell will get killed by the immune system. And so the immune system is surveilling constantly and looking around looking for cancerous cells or precancerous cells long before we ever would have a clue there was something wrong. So if you think about that our immune system's designed fundamentally to be able to kill cancer, and then there are some times where those cancerous cells sneak through the army that is our immune system, what immune therapy tries to do is to strengthen the immune system or boost the immune system or try to block signals that tumor cells use to hide from our immune system. And that way we get both of the benefits, right? We get the power and the smartness and the intelligence of our immune system to fight cancer, but sometimes it needs a little bit of help. And so what we'll talk about today with immunotherapy is different ways that we try to educate our immune system, strengthen our immune system, or deploy our immune system basically to make it a bigger army or a stronger army to then send it after our cancer cells.
What are some of the unknowns around immunotherapy right now?
Yeah, so part of it, I think, is, or one thing that I think we can think about is that it sounds really straightforward to just boost our immune system, but it's actually really complicated because every cancer cell is different. And it's not just about the cancer. Every human, every immune system, our own immune systems are very, very different. And so what works in one person against one cancer almost certainly will not be the same in another patient with a different type of cancer, or even the same cancer for that matter. So it's about the interaction between the host, which is us, and the immune system, and then the cancer itself, which is fundamentally part of us, right? It's a part of us that got damaged and then needs to be fixed or it can be killed off so that the host can survive. So it's not as simple when we talk about immune therapy as just globally boosting the immune system and everything's going to be fine. Sometimes we need to direct the immune system as far as what it's supposed to kill, and or try to try to do things that are a little bit more sophisticated. For example, I think one thing people will say is, well, what can I eat to strengthen my immune system? Gosh, if there was only a vitamin or a pill or some sort of magic superfood that would just do that, and then all of a sudden our immune system is perfect and can recognize things and kill off cancer cells. And it's not that easy. Certainly, we know that vitamin C, for example, can help boost our immune system during times of the common cold, and that's why people take airborne or echinacea or some of these things that are thought to strengthen the immune system. But it's not quite enough probably to go after something as complicated and as evil and tricky as a cancer cell is.
One thing real quick, if I can just jump in, just to reiterate a point that you said, I think that's really important for patients to understand, is that, excuse me, you mentioned this sort of there's pre-cancers and the immune system can kind of fight to prevent those from forming. But I think it's really important to drive home the point that this is a very dynamic thing. And there is this sort of push and pull, or this sort of, we always use this like fight analogy. Maybe it's not the best one, but the fact that your immune system is trying to eliminate this cancer in the beginning, that continues to go on as you're treating the cancer. And then that the aspects of that engagement kind of change over time, right? So that's why even in the same patient, some things may change as you go forward because the cancer is constantly evolving in response to what the immune system is doing. And then the nice thing about the immune system is it can respond as well, right? So it is really this dynamic thing that happens over time and continuously happening, I think. Yeah.
Right. And then there's survival of the fittest, right? So your immune system may be able to kill off 75% of the tumor cells, but if there's 25% that are different or harder for the immune system to find, over time, that's what's left, right? You've gotten rid of the easy targets, and now you're left with a very different group of tumor cells. And that's sometimes why immune therapies or any type of cancer treatment works up front. It works at the beginning, but then as you get rid of the easy targets, the more evolved or the more mutant cancer cells or the smarter cancer cells, or however you want to think about it, figure out a way around those treatments. And so we're constantly having to shift gears to try to catch up. Great point.
You talked briefly about how there's different responses between patients for everybody that's going to respond to things. Do some of those same things come into play as you're kind of evaluating if a patient may respond to immunotherapy, and are there specific cancers that may not respond as well? It sounds like sarcoma was one that was kind of difficult to get to respond, but kind of falling into that same category is like those cells might be the ones they're not quite as easy to target. And so it's harder to stimulate them with the current immunotherapies we have.
Yeah, no, that's a great question. So let me give another analogy to kind of, put a few things into perspective just because it gets a little bit complicated. So let's step away from cancer for a second and talk about somebody who gets a flu shot. Okay. So, or let's say somebody who actually gets the flu, not forget the vaccine. Let's say you get a flu, a virus gets in your nose, and you've suddenly got an infection, a foreign invader that needs to get neutralized. So the flu virus is very foreign, right? That is not supposed to be in the body. And our immune system is very, very good at recognizing that. So this concept of something about the cell being foreign is super important. So if you have cells that don't look foreign, they look normal on the surface, your immune system can't recognize that because your immune system's programmed not to kill your normal cells, right? You're not supposed to attack your own normal healthy body. So there's all these safeguards that are built in there. So concept number one is the foreignness. So that's the first step where some cancers are easier to kill than others, is some just look more foreign and some don't. And what the foreignness comes from is broken proteins. So every cell has this library of billions and billions of proteins that it makes. And as part of like routine maintenance, there is machinery in those cells that chops up the proteins and puts them on the surface like an antenna for your immune system to come by and check. You can think of it like the policeman making their rounds. The immune system comes around and checks the proteins and makes sure everything looks okay. Those are called antigens. So you'll hear sometimes in cancer people talking about, oh, well, there's high mutations. There's high genetic mutational burden. What that means is there's a lot of broken proteins in those cancer cells. And that inevitably means there's a lot of foreign targets that are being put up on the surface for the immune system to recognize. So that's kind of one piece that separates easy kill from not so easy kill. If that happens, let's say that your immune system does get it and it creates a whole response against whether it's a virus or a cancer cell, we want the immune system to do its job. Like for flu, we want you to mount your immune response and get sick and do all of this killing, but then we want it to shut off. And so part of the immune system is under the control of these on switches and off switches. Either go kill or stop, shut down, and go settle yourself down. And because otherwise we'd be sick with flu forever, right? Like the immune system would turn on and then never turn off. So cancer cells can use that to their advantage, and they can put don't eat me signals, or basically shut off signals, and those are called checkpoints, on their surface to say, I'm a good guy, don't eat me, you don't want to kill me, go away. And that's another big strategy that we look for in cancer to try to figure out which tumors are likely to be responding to treatments that block don't eat me signals and try to let the immune system become active and be able to kill them. So there's a lot of other things that go into this process, but I think those are kind of the two big things that we'll talk about today, because that's how we've designed these immune therapies, is kind of at the very beginning, like how do you make a tumor cell look foreign, but then also how do you get rid of the don't eat me signals that shut down the immune system.
So you mentioned sarcoma being a difficult cancer when it comes to immunotherapy.
Yeah.
You started to allude to some of that right here, but could you talk a little bit about what makes certain cancers more difficult?
So sarcoma is kind of the quintessential example. So with other types of cancer like breast cancer, colon cancer, pancreas cancer, many of these same things come into play. So sarcoma is notoriously, it looks very, very much like self. Because sarcomas are bone and soft tissue cancers, right? We have structural cells throughout our entire body that hold us together. And those are kind of everywhere. Like that's a normal cell. Like that is something that's really important to the body to be able to hold us together, literally and figuratively. So sarcomas tend to not have very many mutations, meaning for most of them, there's not a lot of broken things that create foreign proteins and antigens for the immune system to recognize. Probably only about 20% of sarcomas are sufficiently broken for the immune system to be able to really recognize them and then be boosted by just simply, one of these don't eat me blockers, which are called checkpoint inhibitors. And so I'm sure we'll talk more about those, but those are kind of the simplest of the immune therapies, where it's an antibody that blocks a don't eat me signal. For that to work, your immune system has to already have gotten through the whole process and made an army that's specific for those cancer cells that just needs to be let go. It just needs to get the don't eat me signals out of the way, and then it can go to town. So that's one group where you can boost that if the immune cells are there. But if they're never had a clue there was a problem in the sarcoma, or it was always blind and never bothered to form any sort of immune recognition, that's a whole other big problem. And that's the case in other types of cancers too. Like pancreas cancer, for example, is a very immune cold tumor, which means the immune system just has a hard time figuring out there's a problem going on.
Yeah, I think that comes up a lot in kidney cancer, like clear cell is pretty active for immunotherapy, but chromophobe kidney cancer, which is one that I advocate for a lot, has often been described as a cold tumor because it doesn't have like an immune response to it, and it doesn't typically respond to immunotherapy very well. How in sarcoma has there been ways that people have been trying to work to turn the cold tumors hot? I've heard a number of different strategies trying to be tried, everything from like radiation and combination ablation and those kinds of things. Have any of those things come into play in sarcoma?
Great question. So yes, we have been, people have been doing a lot of different combination treatments with really checkpoint inhibitors, which are the antibodies that block the don't eat me signals. That's sort of the backbone of everything. So, but again, if you don't have the immune system ready to go, you can turn on and block the don't eat me signals all you want, but if there's no army, nothing's going to happen. So if we look at what other cancer treatments have explored, they've combined with chemo, radiation, pills, what we call targeted therapies that are designed to reprogram the way the tumor cells talk to each other. And that hits a lot of that whole family of drugs hits a lot of really important things like blood vessels that feed the tumors, or how immune cells and cancer cells get nutrition, and how leaky the whole environment is. Like, is it a very is it easy for the immune system to kind of break through the walls of the tumor and get in there? Because it's got to be up front. The immune cells have to be right up to the tumor cells to do anything, or are they kind of stuck outside from, some sort of capsule or lining that prevents things from getting in? So for sarcomas, like I said, we've been behind, but we actually have been able to run, a growing number of these combination trials. And the problem with how we do studies in rare diseases is we're limited by numbers, right? So we don't have, thousands of patients like we do in breast cancer to do some of these big clinical trials. And so, sarcoma in particular is a zillion different diseases. You talked about, chromophobe kidney cancer versus clear cell. We have over 100 different types of sarcomas that sometimes we'll all get thrown into one small 20 or 30 patient study where we're combining these things together. So we're kind of limited, but we've done some early explorations and looking at chemotherapy with checkpoint inhibitors, or chemo pills, these targeted therapies that reprogram the microenvironment in combination with checkpoint inhibitors, and some other things. So yes, we are trying, and there's been some signals of activity with that approach for certain types of sarcomas. And even within those subtypes, certain subsets of patients will do better. But again, like finding like the one combo that works for everybody, we have not yet gotten there.
But when you're thinking about, when you're thinking about who's a candidate for immunotherapy, what types of tests are you doing, or what types of biomarkers exist to help patients understand if they're a candidate for this type of therapy?
Great question. So, we've talked a little bit about those markers, like the high mutations or the high expression of a don't eat me signal. Something called PD-L1 is the most famous don't eat me signal that the tumors can use. So those two things work really, really well to find patients who are likely to respond to checkpoint inhibitors in other types of cancer, but they actually don't hold up that well for sarcoma. And what I mean by that is that, we can do these genetic tests like sequencing and other things to look at the tumor, because if my patients come in, they're like, well, if I don't have the don't eat me signal, why would I respond to immunotherapy? And while it can help if it's there, if they have PD-L1, that's a promising sign. I have a bunch of patients that responded to immunotherapy that didn't have high mutation burden, meaning there was not a lot of mutations in their tumor, and they didn't have PD-L1. So that's what I'm saying. Like the markers we use for other cancers don't necessarily hold true. That being said, there's a couple things that I always look at when I'm bringing a patient and talking about immunotrials. Immune therapy is a double-edged sword, right? It sounds natural, like we're boosting our own immune system to fight the cancer, but it's not natural. And when you get rid of don't eat me signals on cancer cells, you also get rid and block don't eat me cells on your normal cells. So patients can get inflammation from the immune system attacking them anywhere, head to toe, any organ. And usually it's mild and it's something we can manage, but sometimes it can be very dangerous. So in patients that already have underlying immune issues, so say somebody that has rheumatoid arthritis, for example, which is a disease where your own immune system attacks your joints, or something like Crohn's disease, which is where the immune system attacks the bowel, those patients, it would be very dangerous to put them on immunotherapy because we're really going to make their immune system and underlying problems even stronger, right? So the patient has to be safe for that kind of approach. The other thing is immune therapy takes a while to kick in. And if you're talking about just putting somebody on a checkpoint inhibitor, people will get worse a lot of the times before they get better. What that means is the tumors, if they have a big sarcomas or big tumors in their lungs, and we boost the immune system, even if it works, those immune cells are going to go into those tumors and swell and get angry and hot and maybe make a lot of fluid or like our inflammation type of thing, the mucus and all that stuff. So patients can actually feel worse before they feel better. And that process can take anywhere from 6 to 12 weeks. And that's assuming the patient's going to actually respond, which not everybody does. So if I have a patient with a sarcoma that's growing really, really fast, I would be worried about having enough time for the immune therapy to kick in by itself, right? So we have to make sure there's time for the immune system to actually do its job and to give it a fair trial without the patient being at risk for, getting too sick from their cancer. Does that make sense?
I just want to take a quick step back to something that you mentioned earlier. And that is that subset of patients who look like non-responders, but actually surprise you and respond. I would just love to hear, I know we don't know definitive answers as to why this exists, but what are some hypotheses that you have around what's happening there?
Yeah, that's a great question. So you're talking about the tumor looks very cold at base, they don't have a lot of things going on, and then we try it, and then lo and behold,
it works.
These miracle responses. Yep. So that is what my entire lab is focused on trying to understand, as are, we don't have a ton of people doing immunotherapy in sarcoma, but the people that are obsessed with immunotherapy are super obsessed. And clearly in the rest of the field, everybody's looking at trying to find these explanations. So a couple things. I think sometimes it's not about the number of antigens that are in a tumor, although that is nice for other types of cancer where you have that luxury. It only takes one. So I'll give you an example. There's a disease that is near and dear to my heart called alveolar soft part sarcoma, which is actually very similar to a special type of kidney cancer as well. They have what's called a translocation, which is where two genes that are miles apart from each other get flip-flopped in some fluke genetic event that has no reason or rationality, but those two genes get stuck together and suddenly take on a life of their own. So the control of gene A is now stuck to gene B, and gene B, which normally should have been turned off, is going haywire, right? So that's a translocation, which means one genetic problem that drives the entire growth of that cancer. Historically speaking, when you only have one genetic problem, why on earth would there be enough foreign things in that tumor cell to trigger the immune system? Well, alveolar soft part sarcoma is like that. And it turns out that's actually the most sensitive tumor type in sarcoma that we have to immunotherapy. And we figured that out by accident, right? We put these patients on and suddenly we're watching tumors shrink. We still have no idea, what it is about that protein or that fusion or that disease that makes the immune system be able to find it. I think, sometimes there could be a protein on the fusion. So when the two genes come together and they make a new shape, something about that shape can be recognized by the immune system. That's one possibility. Other times, it could be just like there's one antigen and that's enough to drive everything. Or maybe it's just that, the control of how the immune system behaves, somehow, like with the immune therapy and turning up the volume on all those responses, that we're still able to overcome just one particular signal. I guess what I'm trying to say is that, people have described the immune system as like an onion. So there's like all these layers. And just when you think you've fixed like one problem, there's another layer that kind of disrupts things. So, I think in each patient with sarcoma, that balance between blood vessel growth or nutrition or these things, the microenvironment is so complicated, that until we have a way to figure out exactly what the broken problem is or what's keeping the immune system out in that particular patient, sometimes we get surprised and the immune therapy can still work. Sorry, that was a very roundabout explanation. Does that make sense to people?
Yeah. No, yeah, I think so. You talked a little bit about the microenvironment. Mm-hmm. What do you mean by that? Tell listeners, like, what do you mean by that? And like, are there ways for patients to know about their tumor microenvironment and what exactly is happening there?
Yeah. So the microenvironment, you can think of it as sort of the landscape around the actual tumor. So say, you're in a field or something, and you've got the trees that are growing in the middle of the field, like say those are the tumor cells. So the microenvironment will be everything that's around the tree. So the dirt, the root system, right? The air environment, like everything that's around it and helps that tree either grow or not grow. So in a tumor, not only do we have the tumor cells and the immune cells, but there's the supportive structure that's around the tumor. So something called stroma, which actually, ironically, is often normal soft tissue cells. So the same cells that get broken and become a sarcoma actually are normal, and they're supportive connective tissue cells that hold everything together. So those are involved in the microenvironment. The blood vessels that feed the tumor and the surrounding area are very important. So when you have crappy blood flow, so the blood cannot get into the tumor or the microenvironment area, that means there's low oxygen. That means there's low nutrients. That's all the things that normally get carried around in our bloodstream to our healthy cells might not be getting into these giant tumors as well. And that is important because tumors can thrive on those kinds of states, on a very acid state, on a very low oxygen state, but normal healthy cells can't, including immune cells. So you try to get T cells to go into a really nasty acid environment, the T cells might poop out. They might not be able to function like they should be, and that can also limit it. So that's an example where, a drug that helps the blood vessel flow get better or improve the flow throughout the tumor might help disrupt the acid, might help get a little bit more oxygen in there, and maybe the immune cells then thrive a little bit better. So that's kind of what we mean by the microenvironment.
So are there ways that patients or that physicians know what's happening in the microenvironment?
Yeah, that's a great question. It's been described. So, we've seen like people, this is the science part of it, right? They've talked about an immune hot microenvironment where there's plenty of immune cells in there. And obviously things are running much better, where there's, the cells are not dying. That's called necrosis. So that one sign of a very poor microenvironment or an environment where there's not a lot of oxygen is the cells are just dying like crazy. And it's almost like a rotten orange in the middle where there's just goo and like not really much of anything. So sometimes we can make guesses about that by the way things look on the scans. So by a tumor that's really, really big and then very liquidy in the middle, oftentimes I suspect is probably necrotic. But again, like we don't have the tools to know, how well the chemo is going to get in there. We can guess, and I can say, gosh, this might be really hard on a tumor on the size of a grapefruit to get immune therapy, to get immune cells in there. But sometimes we don't know. And we can look at the tumor under the microscope and make guesses about these things. But every little part of the tumor might be a little bit different too. So it depends on where you stick the needle, right? So for our patients, I wish we had a way to say, this is the sort of tumor that is definitely going to respond and you've got all these things going for you. That's where the science needs to go. And eventually we might be able to do, some sort of biopsy test or looking at different pathways, immune pathways that are up and down in a particular tumor and say, this is the exact type of immunotherapy you need with this combination to deal with this broken pathway, and a pill to help your blood flow because its oxygen is very, very low. Like that's the home run, right? Is if we can tell a patient you need this, and this because of what we've learned from your tumor, but we're not there yet, even in research.
There's probably two quick things that are worth saying practically, just to link this discussion to kind of what patients are experiencing in clinic. Mm-hmm. One is just to emphasize that we really don't know, right? So I'm guessing, at least when I was doing research, I sort of felt this way. You kind of work as a researcher and you know a lot about the little systems that you're researching in your lab. But then you go to the clinic and the best you can do is like look at the scan and like look at the path report. And then that's the information that you get about the patient, right? You don't get like a report about the patient's type microenvironment that helps pick drugs. I think you are getting there. Like we're getting better tests that can kind of help us that way. But there's a significant leap that needs to be made from all the science that presented at these conferences and we get excited about to like acting on that science in clinic. I think we have a ways to go. But the other thing that I just want to reiterate again is that as you're talking, it's like, patients, they have this, we've taught, I keep saying journey is not a good word for it. I don't know that I find a better one, but as you go through treatment, things are dynamic, like we said before, right? And so you could have an immunotherapy that's a great plan for an alveolar soft part sarcoma, and then you start treating them and they might do excellently. And then 2 years later, maybe a metastasis pops up. And that we do actually know from studies that across cancer types, those metastases can be genomically, immunotherapeutically, microenvironment could be different, totally like basically a new cancer from your perspective as the oncologist that's trying to treat the patient. And I think that really makes why it's sort of like you hear about all these exciting things. And then for some people, it's hard to kind of get over that hump of what we don't know.
Right. Yeah, you're absolutely right. And the one thing I'll just add to that, but one of the things that's so important is when I run clinical trials, almost every early phase trial that I run, we ask patients to give a tumor biopsy, which they're like, what? I've already had my tumor removed. You've got tissue in the hospital. Like, why are you going to stick a needle in my tumor right now? Well, it's because I can do that, right? I can take that fresh tissue from a patient that we're going to follow and see how they're going to do on immunotherapy. And that can go back to the lab in real time, my lab, not like some random lab. And actually we pull the immune cells out right that day. We can put it in a mouse to try to make the tumor take place so that we can study it later. We take a ton of blood samples and they're like, why are you vampiring me? I'm like, because I need your immune cells so that we can, create this microcosm of you. Like we are literally creating little avatars in mice of these patients who are going on these trials. And, I may not be able to tell them when they go on the trial, this is going to work for you or not. But when we learn if it does or not, then I can go to the mice and the blood samples and all those T cells and say, what is it about these T cells that's different than the people that did well or didn't do well? So that's why for patients to know whenever you go on these early trials, we need that link. And that's so important to ever get to that point where I can say, yes, you have this, and this, and we should do this, and this.
One of the things that you mentioned was like I think this kind of plays on two things that you said together. One of them was you mentioned how like if a patient, when you're trying to decide if they are a good candidate for immunotherapy, part of it is like, do you need an immediate response essentially? Mm-hmm. And I've seen, for example, in the kidney cancer space, I think there's some discussions currently of like a Ipi-Nivo, so like dual immunotherapy has more long durable responses, and the curve is holding a little bit longer versus immunotherapy and a TKI. I think there's still some stuff that they're still trying to tease out to see if that's actually what's happening or not. But I know some patients, for example, might be put on immunotherapy plus a TKI in order to be able to get the response from kind of one or the other or both, to be able to drive some of that response. And one of the questions I had is you mentioned some of the things that play into these factors of like, if you don't have enough oxygen in the area, or blood flow to the area, that sometimes you can try to increase the blood flow. And I was wondering, because TKIs, I believe, often kind of restrict the blood flow, but I might be understanding the purpose of what TKIs do there. And I was wondering if you have any insights on like how they interplay with immunotherapy. I know there's a number of different TKIs used across different disease types, not necessarily just for kidney cancer.
Yeah, no, that's a great question. So I will say everything we need to know about TKIs and immunotherapy and sarcoma, we learned from kidney cancer because you guys did it first. And I will say, I remember, when I was writing the axitinib and pembrolizumab trial, which was my first study, I met with Brian Rainey, who is one of the gurus who in the kidney cancer world. And I will always remember being at this workshop and him sitting down with my protocol and being like, no. We learned in kidney cancer, you got to go up on the dose, you got to go down on the dose, you got to do all this. So I will say there's a lot of some of the most exciting trials we're doing in sarcoma are based on what we've learned in kidney cancer. That being said, kidney cancer, and I'm talking clear cell, like more of the mainstream types of kidney cancer are extremely dependent on blood vessel factors, on what we call angiogenics. So all that stuff about blood vessels that feed the tumors or don't feed the tumors, that is fundamentally important in kidney cancer. And most cancers are not that extreme, including sarcomas. Some of them are, like ASPS, but most of them really aren't. So when you look at TKIs, and a TKI is a tyrosine kinase inhibitor, which is essentially a pill that blocks a master antenna. Actually, it blocks about 20 master antennas that carry signals into the cells from the microenvironment, from the outside, and program all of these different things. So like their communications, their ability to metastasize and spread, nutrition, metabolism, all blood vessel growth, all those things. It hits a lot. So it's really, really hard to sort out which of those pathways is important when you're hitting 20 different things at the same time with some of these drugs. And that's important for blood vessels too. So in theory, if you have a TKI that primarily hits VEGF or vascular growth factor, then yes, you may at times make the blood vessels leaky, but then also at times you may tighten them up because we want the blood vessels to be acting like normal blood vessels, which typically are a bit tighter than tumor blood vessels. And the regulation of that goes up and down depending on where you are with treatment. So it gets really, really hard to kind of unravel, is it good? Is it bad? Is it working? Is it not? But what I will say is that VEGF, along with many of these other proteins that are hit by TKIs, they all affect the immune system in different ways. There's a very famous guy named Gabrilovich who, is now with industry, I think, but did a ton of work showing that if you block VEGF, you promote the good guys of the immune cells. So every immune cell comes in a go kill them format and a stop killing them and shut it down format. There's a yin and yang to every single type of immune cell out there. So VEGF is a master regulator of the balance between the kill cells and the sleepy cells, like the don't kill cells. And so you can see when you block in cancer VEGF, there's a shift to good cells, to killing cells. And that's across a variety of different types. So it just totally reprograms the immune interaction. But again, difficult to predict and difficult to understand which one of those exact points is super important. But yes, so we have in sarcoma, we've combined axitinib. There's a trial that just came out very recently that was presented at ASCO that we were involved in with a drug called cabozantinib, which is like it's like super exciting drug that hits a lot of different things. But man, that looked good in combination with the immunotherapy in sarcomas compared to the cabo alone. We stole that from kidney cancer too, by the way. But
so on that drug, so
the point is, yes, that is. So there's something about those drugs that really does reprogram the microenvironment. But it's super hard to try to understand like which part, it's a chicken or egg, like is this causing this or what actually matters when you're designing these treatments. Huge amount of research going on there though. I don't know if I answered your question either.
Yeah, you did. It's very interesting. It makes sense why there's like as a patient, I know early on before I kind of started learning and following these different things, I was like, why are you trying 7 different TKIs with an immunotherapy? Is there really going to be that big of a difference between them? But as you've been talking about here, I can see how some of those might be able to help tease out some of those differences of like, you can see where the overlaps are, or at least the idea would be that you could be able to see where the overlaps are and try to identify what's driving what.
Yeah, the whole thing with the TKIs and all those drugs is you're trying to fix the surrounding microenvironment to be a more happy place for the immune cells to go, that then you're boosting with the don't eat me signal blockers or checkpoint inhibitors, right? So with all of immunotherapy, you can think of it as either acting early, like trying to make the tumor more foreign, potentially fixing the surrounding environment, which is the TKIs. And then at the very, very end, when you are assuming your immune cells are there and in the building, just turning them on full blast and making them go to town. And so that's kind of how I think about immunotherapy in general.
Very interesting.
One question I wanted to ask was, often in sarcoma, immunotherapy is saved for maybe after you've gone through more standard rounds of, more standard of care, which tends to be chemo. So, as a patient, how do I think about, or is there any data that would suggest maybe responses to immunotherapy are lower in heavily pretreated patients? Or how do I think about that and the idea that, chemo is notorious for kind of eliminating certain parts of the immune system, and immunotherapy is like boosting. So how do we think about that as a patient? Do you encourage patients to think about immunotherapy earlier in the process versus later, or how do you counsel patients on that?
That's a great question too. Oh my gosh. There's one short answer, which is that I actually just saw a clinical trial presented at ESMO, which is the European Medical Oncology meeting. This was just in a couple months ago or last month. I don't even know what month it is. I think in October. Anyway, so the Europeans had done this really crazy, gutsy move, which was, let's do a clinical trial where you randomize patients who have been untreated. So these are brand new sarcoma patients to either doxorubicin, which is the standard chemotherapy drug that everybody gets and everybody hates, the red devil, or let's do PD-1 and CTLA-4 with durvalumab and tremelimumab up front. So in the United States, I think it would have been hard for us to do that, because if you look at the response rates, meaning how many people shrink with immunotherapy alone, even in the refractory setting, it's less than 20%. And granted, chemo is not that much better, but that's, if they happen to be in the 40% of patients that grow on immunotherapy badly, at least with doxorubicin, most patients stabilize. But if you had to be a bad progressor with immunotherapy, yikes. I mean, so there wasn't enough data really for anybody to necessarily feel super comfortable with that. That being said, I was so excited to see it, because that's the question that we all ask, is maybe we're just doing this totally wrong and we should be giving people immunotherapy right away and before the tumor gets smart and, whatever. So it turned out there were some problems with the study, because the doxorubicin actually did really badly. The response and sort of how the patients did was worse than we would have expected. But the two arms were fairly similar, which was kind of crazy, because I was like, wow, I mean, neither one were good. We both were horrible. But at the same time, it was surprising to me that the patients with immunotherapy actually were about the same as standard of care doxo in that trial.
Yeah.
So something you said that is sort of my something I think about all the freaking time, which is basically chemotherapy suppresses the immune system. So if we talk about doxorubicin, you're right. Over time, when people have gotten 4 or 5, 6 cycles of treatment, and certainly during the recovery period after chemo, where the immune cells are low, the red blood cells are low, the platelets are low, yes, it does suppress the immune system. But when you first expose a cancer cell to doxorubicin, magic happens, because the cancer cell kind of explodes, and it also starts to trigger the same pathways that would be expressed if that cancer cell had a virus in it. So these are called type 1 interferons, something called damage associated molecular patterns, or DAMPs, pattern associated, all these immunology terms, but they're eat me signals is essentially what they are. So that first moment where the chemo hits, before the immune cells later dump down and all that sort of thing, there is this robust eat me signal that goes out. And that is a golden opportunity, a window of opportunity, where the immune system is going to actually go there and say, holy cow, this is bad. I'm going to get educated and do my thing. So this is where the idea of combining doxorubicin with checkpoint inhibitors to boost the immune cells comes in. And I think this is the most exciting thing I've seen from combinations. And so there's been 2 studies done with doxorubicin and pembrolizumab together. And then we just presented our trial, which is dox plus PD-1 and CTLA-4 blockers together. And there's a lot we still don't know, like, should you do immune therapy and then the chemo? Should you do them together? Should you do the chemo and then the immunotherapy later? Like, there's all these ideas that we need to understand more. But there are signals that the combo may work better than either one alone. And Seth Pollack, who's at Northwestern, is going to do a study for sarcoma patients where they get either pembro alone versus doxorubicin and pembro together. And I think that study will be really interesting. And I think he's only limiting to a type of sarcoma called UPS. But, so that's the kind of thing that we're really excited about, because it's eat me signals, and then you block the don't eat me signals, and you take advantage of the immunology that's happening there to try to make it work. And of course, it won't work for everybody. And I think I have some ideas about the patients who respond to docs and the ones who don't get those signals that we're trying to tease out in lab. But I think that's what we should do. So early on, if you're going to treat with chemo, I think you can do better if you have the immunotherapy at that point too.
That ESMO study, I definitely want to, I wonder if we can link it for people. Was it something that was reported out, or you just kind of talked to people about it at the meeting?
No. It was actually one of the, I forget what they're called. It's one of the big abstracts, the paper sessions.
I can definitely look and link it. It's one thing that's remarkable is that I immediately thought of that study's kind of been done before with different types of chemo, and it didn't work, right? So it makes it even a little bit more brave in a way that that design of taking doxorubicin versus some specific chemotherapy. There was a trial that did that, I think, in a while back, and it kind of wasn't super successful. Like, it's kind of hard to unseat doxorubicin as the winning therapy for
right. And they looked at overall survival. So they didn't even just they went straight for, do patients live longer? Not even like the response rates or shrinkage rates. They were like, we want to see if there's that tail. And you'll know about this in the kidney cancer world, where there's certain patients where even if they don't respond really great to immunotherapy, they still live longer, way out. And so that, they were looking for that signal, which is, it's very bold and like super cool.
Yeah. One thing I wanted to say really quickly, just to nail down the point for people. So is it still true in sarcoma early on, it was evident that some types of sarcoma are much more responsive to immunotherapy? And so UPS, or undifferentiated pleomorphic sarcoma, I think leiomyosarcoma is the other big one. And is it still true that a lot of trials now are limiting to those types? So they're trying to be specific for those types of sarcoma. You mentioned it with Seth Pollack's trial, he might limit it to a certain histologic type. Are you seeing now more in sarcoma trials that they're kind of being more agnostic to histology and they're kind of including other types? This is a unique issue in the sarcoma world that I think sometimes other types of cancer don't face, just because they don't have 100 different types of cancer all lumped together.
Yeah. So, and I think there are certain types of cancers where this is really important to do it this way. So like chromophobe renal cell carcinoma, uveal melanoma compared to standard melanoma, I think is a totally different disease. And so, yes, I hope that our other rare tumor colleagues are learning from what we try to do in sarcoma, which is, as much as possible, if we can, the less number of subtypes you put in, the less number of diseases you put in, the more likely is you're going to see some kind of consistency. And, so the super responsive to immunotherapy is so relative, right? And it's what you think that means. So ASPS, more than 50% of patients respond. That is a super hot responsive tumor, right? UPS is about 20%, which means that even though these tumors, still have immune cells inside of them, if you look, many of them have PD-L1, some have high mutation burden. 80% of those patients, it's not going to do anything. Like, it just doesn't work. And leiomyo is probably a little bit worse. Leiomyosarcomas in general are somewhere between 5 to 10%. Liposarcoma was originally a big hope for one that turned out to only be about 10%. So I guess it's better than 1% or 0.5%, but it's still, if you're a patient and you're like, well, you got a 2 out of 10 shot that this is going to do something for you, that's not great to me. And then the other thing, so the Europeans were looking for, and they found, in the tumors that they looked at with sarcoma that were very, very hot, or the ones that had a lot of immune activity and responded to pembro by itself, they had these little clusters of immune cells inside the tumors called tertiary lymphoid structures. And they went on to do a trial where they looked for those things and then put the patients on the study. And it helped a little bit. Like I think the response rate went up to about 30 to 40%, but it wasn't perfect. So again, just to your question earlier, Julie, is just like, we don't have the right biomarker to find these patients. But yes, so I think in general, we're trying to do the more limited you can be in who you put on a trial and keep the consistency there, I think the better off you're going to learn. But at the end of the day, we need to learn something from every single patient who goes on every single trial. And that means understanding as much as we can about their immune system and the tumor and the blood and their side effects and everything. And yes, it's a lot of data, but we just don't have the luxury of, thousands of people to treat like this.
Yeah, I think it's interesting, like having a rare cancer myself. As a patient, I think that there's a balance between, like, for example, when I was initially diagnosed, the two drugs that I had to choose from versus the exact same drugs were available to me in a trial. But both of those drugs were available to me because there was a more broad trial that allowed me access to those drugs, which I think is really important to patients. But at the same time, there's this other subset of exactly what you said for like chromophobe, and it sounds like the exact same applies for like sarcomas. There's these different subtypes of some cancers that are the biology of them is so different that if you include them in these basket trials, you really lose responses in the noise. I've seen that like in some chromophobe responses to therapies. Like if you've got everybody bucketed together and there's one subset of population that really responds, but that gets lost because everybody else didn't, then you don't really learn what you need to learn for those patients. So I think it's an interesting problem that you guys have to have, or that you guys have and have to balance between like these broad trials that give access to these treatments kind of across the board so patients have options to even try, but then also making sure that the disease specific, that you're going after the biology of those specific subtypes.
And it's so messed up how we do these trials too. So let's say you have a group of 30 patients with all these different things, and you're very open because the patients want to be able to go on trial, right? So like eligibility is the worst. Try to explain to a patient, well, the company only wants you to have, this subtype. Well, why? They picked that, right? So, to exclude patients based on these things is really hard. But then you put everybody in. Let's say one or two patients have these incredible responses and the other patients don't. But it was life-changing for those two people. The company looks at the overall outcome, right? And they may make decisions about whether or not to move forward based on the whole thing. So that's why these drugs die, is if we do the study wrong and we pick the wrong criteria and we put too many different subtypes, and we jeopardize being able to have those drugs in the future. So it's hard to explain to patients, but man, there's not a great solution either way.
Yeah, definitely. I know as a patient, for me, I think it's important that, like, I know as a patient, I appreciate there being broad approvals for like, okay, we're going to base this approval for like all kidney cancers, but then also those trials that like are separate, that really are subtype specific and kind of like narrowing down. Cause I mean, you end up with a much more broad trial, but then the smaller trials seem a little bit more feasible as well to do. Feasible to a certain point. If you're doing trials in rare diseases and rare kidney or rare cancers in general, it's hard to enroll once you get too far down into a subset. But I think it makes the results a lot more applicable. So.
Okay, I've got one more question that I've got to ask, because This is an area that is just interesting to me as a patient who, may one day have to consider immunotherapy. One of the unknowns about immunotherapy is this idea of hyperprogression. Mm-hmm. You talked about this a little bit in that earlier on when you talked about things might get worse before it gets better. That's really the idea of like pseudo progression, right? It looks like on the scan that things are getting worse, but maybe it's really just immune infiltration. But then you've got this separate issue in a separate issue with some patients where it's not pseudo progression, it's actual progression at a much faster clip than you would have expected. I've done some reading in this space, and it does seem like it's a little controversial. Some oncologists maybe don't even believe in hyperprogression and just call it kind of the natural state of disease evolution. I'm curious what your thoughts are around hyperprogression. Like, in your mind, like, is this a real phenomenon that you see in clinic? And then two, are there any signals that exist that might indicate that someone is more likely to experience hyperprogression?
Yeah. So this is the gamble of immunotherapy, right? So it's scary. So I have a patient I just put on a study that has angiosarcoma, which is blood vessel cancer in her bones. So I know good and well that in the first few weeks after immunotherapy, her bones are going to hurt like the dickens, right? Because all those immune cells are going to go into those tumors and they're going to get angry and inflamed. That's really bad when she's already in a lot of pain, right? Like, and if it's in the spine and somebody's got horrible pain in their neck, you don't know if that's, you just triggered hyperprogression. You don't know if the tumor is just growing and doesn't care about the immunotherapy, or you don't know if this is like, oh, don't worry, we're just going to ride through it and hope that magic happens on the other end. I mean, 2 weeks onto a study or 3 weeks in with somebody with an advanced cancer, that is a horrible decision to have to make. Right. And a lot of it, we don't know. And it's a shared decision with our patients. And we say, this is why we need room for things to get worse before they get better, because there's a chance that, that I might be wrong. And that this whole idea of, oh, we just got to get through it to the other side is not that we actually hurt you with immunotherapy and we don't know why, or we don't know how to predict that ahead of time. I will say, like, true hyperprogression, it's all about semantics, right? Like, there's certain criteria that people have said, a certain amount of growth that has to happen to call it that. I've definitely seen patients where the tumors doubled in size or tripled in size. And I'm like, okay, well, I'm not comfortable waiting for things to get better. But I have a patient where it also did that. And then we were comfortable and it came down and melted away. So, it's got to be a leap of faith. Typically what I do is I see how the patient's feeling. If the patient's like, I can't breathe, then that's probably not going to be somebody that I'm going to be able to coast through. And remember, like, you can't undo once the immunotherapy is in there, it doesn't go away. Even if you're not getting the drug, you've already put this antibody into people and the immune system is turned on whether you like it or not. You can't really reverse that completely. So even if you chicken out and you're like, I've got to stop the immunotherapy and put somebody on chemo, I just told you how I think like immunotherapy makes the chemo work better anyway. And we've seen that where people that progressed on immune therapy and then go on to chemo, they do pretty good. Like, there's something about that mix that may actually make up for that. So I try to not put people in danger. If clearly the tumor is getting worse and clinically symptom wise, they're getting worse, chances are it's probably the tumors are just resistant to the immune therapy and that we should move on. But we've seen it often enough both ways where, there's still that hope. And if a patient's feeling great, even if their disease looks awful, then I'll ride it for a little while.
And although there's not a like off switch for the immunotherapy, but there are ways that you can dampen the immune response, like with steroids and stuff like that. Is that typically how you normally, like, if you see that hyperprogression in a patient or you see some really bad side effects of it attacking the immune system instead, is that typically how you taper it down? Or what actions do you take when you see a patient isn't responding and you have to switch to another treatment?
Yeah, I typically don't use steroids to shut down the immune response in hyperprogression or if the disease is just progressing, because typically steroids are just bad in general. And I like to think that still, even if the tumor is outwitting the immune system, that there's some cells in there that could be doing something. Certainly if people are getting immune toxicity, which means, their lungs are inflamed because the immune system has now gone to town on their lungs and they're coughing and things like that, then of course we use steroids to shut down the immune system to protect their normal organs. But I don't think people have thought to do that in the setting of hyperprogression. We typically would just use some other type of therapy.
Gotcha. Okay, that makes sense. I know we have, I don't know if we might be skipping a question here, but I'm excited to hear your thoughts on what you think is most promising for like next gen in the sarcoma space in this area, like TIL therapy, NK cell therapy, kind of anything in those categories.
Yeah. So I think, the two big things that get a lot of attention are vaccines, which is an effort to try to tell the tumor, or tell your immune system what it's supposed to be recognizing and not relying on the tumor to do it. There are some exciting things that people are doing with vaccines, and I think they should work better than they do, but they probably need to be done in combination with a lot of other things to suppress all those layers of the onion we talked about. So like vaccines in combinations with microenvironment repolarizers, definitely with checkpoint inhibitors, because if you get shut down after you've had that immune response, you're not going to do much. So I won't talk too much on vaccines, although, with the new COVID vaccine technology, like the mRNA stuff, which has been around for a while with cancer, I think we'll see some more promising things with vaccines over the next few months to years. My bigger thing is sort of bypassing the entire process altogether and going straight to cellular therapy. And so what cellular therapy is basically, if you have a target, a broken protein or something that your immune system can recognize on the tumor, you can collect immune cells from a patient, engineer them to be specific to go after a particular protein of interest, because every immune cell, every T cell or natural killer cell can have receptors to kind of recognize certain antigens. T cells do antigens, natural killer cells are a little bit different, but you could program them to be specific for a target, expand them into billions in a lab, and then give them back to the patient. And there's several flavors of cellular therapy, including CAR T cells, which have been very, very successful in blood cancers like leukemias and lymphomas, because all of the leukemias and lymphomas that are being treated have a protein that is really, really easy to get with an immune cell. Solid tumors are typically a little bit different. The CARs idea hasn't been so great because, again, solid tumors tend to have very few targets that are only on cancer cells and not on normal cells, particularly sarcomas, where we have connective tissue everywhere and there's just not that many cool targets to go after, although there's some exceptions, which I'll mention here in a second. And then finally, TIL therapy is where you basically take a tumor chunk out of a patient, and there are going to be immune cells in that tumor that are theoretically there for a reason, which is that they recognize some part of the tumor. So by dissolving the tumor or chopping up the tumor and letting the immune cells come out, you can then use those, they're called tumor infiltrating lymphocytes or TILs, to expand into a giant body of an army of cells as well that you can then give back to the patient and theoretically a personalized treatment. So John Mulinax, who is a surgical oncologist at Moffitt, actually presented at the sarcoma meeting just a couple of weeks ago, a sarcoma-specific TIL trial where they had done exactly that. And I think they still have some tweaking to do, but there was a patient who had some stabilization of disease. So I think still a lot of work to be done there. But what a lot of companies are doing with TILs is engineering TILs now. And so putting in these constructs to make the TILs work better, to make them recognize something particular. So a lot of really, really cool stuff going on there that I'm really excited about. And then, for synovial sarcomas and a disease called myxoid liposarcomas, they do, and some types of other solid tumors like lung cancer, ovarian, a few others, there is a group of proteins that can be expressed called cancer testis antigens, which are normally not found on normal cells. So this is something called NY-ESO or MAGE-A4. And so we've actually done a T cell therapy study, a couple of them for synovial sarcoma in particular, that are in late stages now. There's a phase 2 for MAGE-A4 T cells that has had some pretty promising signals of activity. So again, doesn't work for everybody. We still don't completely understand why it works or doesn't work. But at least there's some really cool technologies for our cancers that are coming out.
I know we're going kind of long, but I really wanted to ask this question, and we sort of skipped over it from the outline. It doesn't have to be our last question, but maybe I'm actually curious about this. So we wrote down microbiome, hype, or reality. Are there any dietary recommendations for patients going on immunotherapy? That's the question. But I actually would say, I guess I would want to be curious to hear your answer first about whether you feel like the microbiome in general, so this is like the healthy bacteria that live in the gut or other areas of the body, are they impacting the immune response to therapy and cancer care? I'll just tell you that to me, there's enough like smoke hiding the fire that I feel like it has to be something, but I know that the data is kind of all over the place at the moment. So I'm curious to hear what you say about that.
I believe you too. I totally agree with you. I think your gut is so important to your immune system. Now, That does not mean, however, that it's a simple thing to just tweak and like magically make things happen. Like, again, oh, well, if I eat nothing but, rutabagas, suddenly my immune system is going to be repolarized and I'm going to kill off my cancer. Like, that's never going to happen. So again, because the gut is different for everybody, right? So the exact a conglomeration of billions and zillions of bacteria and things that are in everybody's gut is different from patient to patient. So that matters, and the diversity and how many different species of these things you have matters. But again, it's the interaction with the host. So you have a ton of immune cells in your gut. Like, those immune cells are constantly looking for stuff that you're eating, causing inflammation or not causing inflammation. And it's just this huge source of exposure for your immune system to generate responses or not. So I've actually, I've seen it both ways, right? So, one example is, people that have celiac disease. That's kind of an easy way to think about it. So they are allergic to gluten. So if they eat gluten, the immune cells in the gut recognize the gluten, and then they get really, really sick because there's all this inflammation that happens, right? So you get rid of the gluten and they're okay. In theory, if you change your diet, you do change what your immune system in your gut is exposed to. That can go either way. So like the vegan diet thing, for example, some people go from being inflamed and aches and pains and horribly miserable, and then they go vegan and they're like, oh my gosh, I feel like a different person. I feel great. And some of that non-specific inflammation can calm down. There's tons of people that swear by the vegan diet that's done that for them. I personally did a vegan diet for a year and wound up screwing up my own immune system, and I got vitiligo. So vitiligo is where your immune system attacks your skin. And that's the only thing I can see that triggered that, because it came out of nowhere. But again, it triggers your immune system in such a way, these dramatic shifts, and it can be detrimental, right? So for cancer, suddenly going vegan is not necessarily a good thing, or suddenly cutting out and going full keto, right? Or getting rid of all carbs or all sugar, because you can't control your immune system. You can't guarantee it's going to go the right direction for that cancer, and it could make things worse. And you could be more likely to develop immune-related toxicities if you're going to do immunotherapy after the fact too, if you do that. So I think the take home is the microbiome does matter. I think there's going to be more variability because of that interaction with the individual's immune system and what they're recognizing. But clearly there's data that antibiotics that kill off bacteria in the gut are bad if you're going to treat with immunotherapy. That's pretty well established. So we try to avoid antibiotics on immunotherapy clinical trials in general. And certainly the melanoma data with the higher diversity of species being a better thing sure is tempting to say, oh, well, we should be, supplementing with probiotics and prebiotics and all of these different things. But the fact of the matter is a lot of those supplements are done by the time they get through your gut, and trying to like actually figure out how to deliver the right bacteria at the right time, it gets a little bit tricky. So yes, I think there's definitely something there. I think we're not quite ready for prime time as far as telling people what they should do or not do. That makes sense.
Yeah, I think it does. And I think it's probably worth saying too that, we have to also be aware just of the general clinical status of the patient. What I mean by that is, one concern I have just as an oncologist is that if people are interested in dietary changes, a lot of people are, and I understand wanting to do something that they can do, right? It's not like a medical thing that has to be done by an oncologist. But if you end up, if you do switch to a vegan diet, people can start to lose weight and muscle mass and protein. Yeah. And I think one thing that it should be clear is that overarching, someone who's healthy and well nourished is going to respond better to these therapies in general than people who aren't, or be able to recover from side effects or things like that. So that's great though. I was super curious what you were going to say. So I think it's nice to hear that there's a lot of thought being put into it, and maybe it will play a role in the future,
Yeah. No, I think the other thing too, there's so much on the internet, and if I can get one message out to patients, you can put anything on the internet. Remember that you can go on TikTok and say whatever, and there really isn't a lot of regulation or standardizing as far as the quality of the data leading to those recommendations. So diet is probably the worst thing, but I always quote Brian Van Tine, who is probably one of the smartest medical oncologists that I know in the sarcoma field, who does nothing but stare at metabolism pathways all day. You can cut out whatever you think you need to in your diet by following whatever trend or this, that, and the other. The cancer cells are so freaking smart, and they will find a way through these metro subway map metabolic pathways to get glucose and sugar, which at the end of the day is all they really need, and lactate, which is the other thing they need. They will find a way to get there. It may take them a while, but the idea of starving your cancer is so oversimplified that, we wind up seeing harm. Like people wind up doing themselves harm just because, again, you can't really micromanage every last little metabolic pathway. Your cancer just figures out how to do that, unfortunately. So, but talk to Brian about his metabolism work, because I think there are other ways to change metabolism and take advantage of, the underlying susceptibilities that are going to be really exciting. And this is actually not just sarcomas. This is in lung cancers and some other cancers where he's figured out a way to improve the effect of chemotherapy by combined metabolic therapy. So a whole other frontier outside this discussion, but we will find a way to do the metabolism thing, but it's probably not from cutting out Twinkies. Well, Twinkies are pretty healthy anyway, but like if you really want a Twinkie and you're feeling miserable, eat a Twinkie. It's going to be okay.
I love that you said that, because that's really our goal, is to try to get good information out there. It's something that really came through on this particular podcast, was just how complicated this all is. There's no simple answer to any of it, right? So I
wish.
Yeah, we all do. Yeah. All right. Well, final thoughts for you?
No, just want to say thank you for joining us. And I found this very informative. And I really liked a lot of the analogies that you've used to help describe immunotherapy. I think that they'll help a lot of patients that are listening. So I appreciate you joining.
Yeah, this is great. Thank you so much.
Well, thank you for having me. Again, it's the field's changing so quickly every day. There's still so much that we don't understand. It's the giant black box, but all it takes is just, is one patient that's benefited that shouldn't have benefited from these sorts of treatments. Like there's definitely something there. And, participate in clinical trials is the only way we're going to really learn and be able to move things forward and get to that goal, which is where a patient comes into our office and we can say, yep, we've analyzed your immune profile and your tumor profile, and this is the customized treatment that we want to give you. That's what my goal is. And hopefully that becomes more of a reality, in my career and certainly in those that come after me.
Thank you very much. Appreciate it.
Thanks, guys. Have a great day.
Bye.
Bye.